ان شاء الله هنبتدي دلوقتي على موضوع الكونجينيتال سودوارثروزس تيبيا. دي الصوره الكلينيكال اللي شرحها لنا الدكتور اسامه بتاعه الكونجينيتال سودوارثروزس تيبيا بعد ما يحصل فراكشر. It's one of the most challenging pediatric orthopedic problems to treat. هي في واقع الامر ما هيش حاجه هنا عشان بعض الناس بس بيستهتر، يعني هو مش كسر وانا بحط له شريحه. This is very important point. لان بعض الناس هوريك انا في كنموذج للتريتمنت when you face with a fracture of the tibia in a child 6 few months age, just be fixed. بيحط بليت بيحط نيل كأنه عادي. لا, we are talking about something else. Experience of the surgeon. The problem تملي طبعا تملي بنفكر في خبرة الجراح اللي بيجي يعمل عملية. مشكلة تملي ان it's a rare condition. كتير منكم متخيل ان هو بره عندهم خبرة كبيرة. الكلام ده مش صحيح. لدرجة ان كل حاجة يقول لك ان هي لازم تبقى مالتي سنتريك مالتي سنتريك مالتي سنتريك. مالتي سنتريك يعني ايه؟ يعني لما يجي يعمل بحث يختار 5 أماكن بيعملوها فيطلع لك 14 حالة معمولين على مدار 10 سنين في 5 سنترز. يعني خبرة كل جراح تقريبا ربع عيان كل سنة، ومع ذلك بيقولوا لنا خبرتهم العظيمة وكذا. وفجأة الناس يقول لك لا لا لا، ده مش عارف مين في أمريكا بيعمل إيه ومش عارف مين في بتاع بيعمل كذا. Unfortunately طبعا دي خبرة مش حقيقية. When we talk about congenital pseudarthrosis tibia, are we talking about homogeneous entity or it is composed of several disease types? هل احنا بنتكلم على حاجه واحده ولا مجموعه حاجات؟ في داوت تماما ان هي تكون مجموعه، يعني حاجه واحده، لان البيهيفير بيختلف بين حاله والثانيه. What's the natural history? Fracture with the pseudarthrosis in the first 5 years of life. So if you have a fracture early in life, you have to suspect the congenital pseudarthrosis tibia. No fracture repair response. عادة في الأطفال, if you have a fracture in the first 5 years, you will have massive callus formation. But in such a situation, you don't have a repair response. Once established, progressive instability and progressive deformity. ده ما بيحصلش fracture عادي. If you fix it, you keep it in position. But in congenital pseudarthrosis tibia, if you have fracture, you have progressive deformity. The etiology and the pathogenesis is not clear. It's unclear, and the incidence is rare. Neurofibromatosis 1. In 55%, there is an evidence of neurofibromatosis. Some people claim that if you have a neurofibromatosis 1, you have worse prognosis. The pathology. What's the pathology? Now, most of the people think you have a thickened periosteum and the fibrous tissue. So they believe an excision of the periosteum, perhaps with a margin. We don't think so, by the way. Primary lesion, because I'm going to show you many problems. Most of the people now think that the primary lesion lies in the periosteum. Histologic comparison of patients with neurofibromatosis revealed no differences, because some people think that if the patient has neurofibromatosis, it's going to be different. No, it's the same pathology. Classification, Dr. Osama استفاد في classification. Professor Osama discussed all the types of classifications. Unfortunately, none of them provide specific guidance for treatment or is predictive of outcome. We are wasting our time. Each one wants to make his own classification, but of no value, because you don't have a guideline. So you see, this type is going to be treated this way, and this time is of more poor prognosis. There's no evidence. So most of the classifications, are not important to give you a guide. The second important point, after operation, the type of the lesion may alter and the types merge into each other. بمعنى انت عندك حالة عاملة 18 عملية 13 7. When you diagnose this and you put it into classification and you see the first X-ray, It's totally different. يعني كأنك في أول أشعة بتقول دي تايب كذا وفي آخر أشعة ده تايب تاني. إيه قيمة الكلاسيفيكيشن؟ Actually, all the classifications now, they are of no value. I'm going to give an example. This patient of congenital pseudarthrosis tibia had been treated by, I don't know why, by circulage, then plating. And this was the first picture, and this is the last picture. Totally different types. This is in the distal third, and this is in the middle third, and this is the atrophic type. It looks like a cystic type. So which type is this? So the classifications are confusing, very confusing. I don't rely on classifications. Osama discussed Boyd classifications and sick types. Now Crawford is the most widely used classification, which is divided in two types, non-dysplastic and dysplastic. This is the non-dysplastic type, and those are the types of the dysplastic types: sclerosis, cystic, and atrophic type. The treatment of congenital pseudarthrosis tibia, either prophylactic to prevent the development of fracture tibia, because sometimes you get the patient with the anterolateral bowing, and the surgical treatment. What's the congenital anterolateral bowing? It's the pre-pseudarthrosis stage. There's the risk of fracture and pseudarthrosis. So you can get the patient at this stage with the age few months. This is anterolateral bowing. If there is a prophylactic treatment, I'm going to speak about the anterolateral tibial bowing in association with neurofibromatosis 1, which is an autosomal dominant disease. It's a precursor of congenital pseudarthrosis, which is very difficult to treat. This is the patient under neurofibromatosis patches and autosomal dominant. This is dominant. So this is the father. You see the patches of the neurofibromatosis. So anterolateral bowing, this is the lateral view. So you have anterior and lateral if you look to the AP. So anterolateral bowing. And the patient has neurofibromatosis, and the father has neurofibromatosis. If there is a way to have a prophylactic treatment, such a case, because we all know that this is a precursor of congenital pseudarthrosis. Why we treat this patient? Because many people, many authorities say you have to leave the patient for such a long time. If you wait, is it harmful to the patient? Yes. Because you have altered stress-strain distribution. The bowing of the long bones likely results in altered stress-strain distribution, potentially increasing the risk of the fracture. So we are inviting a fracture. However, there is little information on why neurofibromatosis 1 children with long bone bowing and the fracture progress to non-union, while neurofibromatosis 1 children without long bone bowing do not in general sustain long bone fractures progressing to non-union. يعني لو ما فيش anterolateral bowing وعندنا neurofibromatosis 1 ما بيحصلش. لكن neurofibromatosis anterolateral bowing بيحصل الفراكشر والcongenital pseudarthrosis. Remember, if you do an osteotomy, you can invite pseudarthrosis. And look to the picture. All these cases have been treated by osteotomy, osteotomy and deplating, osteotomy and nailing, osteotomy and the free vascularized flap, osteotomy and the Elizarov. They are all ended up with congenital pseudarthrosis tibia. So remember, when you want to do osteotomy to correct the anterolateral angulation, you might end up with this horrible situations. So there is a necessity of prophylactic treatment, which had been overemphasized in the literature. What's the prophylactic treatment? Mostly they speak about casting or bracing till skeletal maturity or bypass grafting. Dr. Hani Mwafi published a paper about radical resection and the Elizarov method. This is massive dissection. And others speak about guided growth. And I got this patient at the age of 3 years, and she came to me with neurofibromatosis. So at the time I told her, wait, 2 years, 3 years, 4 years, 5 years. She's now 6 years. الام قالت لي وجدتها انا مش فاهم احنا بنجي لك ليه؟ انت كل ما نيجي تقول لنا استنى ورجل البنت عماله تتعوج اكتر. They are true. Is it my job to tell them wait and wait and wait? So we have more deformity, more deformity, more deformity. So is this the wisdom to wait for skeletal maturity and invite the asymmetrical of the growth plate? Because for the growth plate behavior, if you apply asymmetrical stresses, it's going to give you more deformity, more problems. So waiting is not a wisdom. Waiting is with, you're inviting more problems. Again, if you have a deformity, you're going to have serious social and psychological effects, especially during adolescence, which sometimes is very difficult to treat. Depression, withdrawal symptoms. So what's a prophylactic treatment? This is the case report about using guided growth as a prophylactic treatment. If we look here, they didn't correct the deformity. Still had they have an angulation. Our hypothesis that we treat the anterolateral bowing like a deformity. We have a deformity in the AP and lateral. So it's an oblique plane C-shaped deformity. So we have C-shaped deformity. We draw the axis of the proximal tibia and the axis of the distal tibia and the axis of the middle segment. So we have two cores, one here and one there. Then we decide the zone of irregularity or the problem using the plane X-ray. This is the zone of irregularity. So we do an osteotomy above and an osteotomy below. This is the mechanical axis of the proximal and the mechanical axis of the tibia and the middle segment. So we do two osteotomies and we correct the deformity from the two osteotomies. And we ignore the site of the congenital pseudarthrosis tibia. Weight bearing on a normal mechanical axis may correct the altered stress strain distribution and prevent the development of congenital pseudarthrosis tibia. And this is an example. Anterolateral bowing and neurofibromatosis, osteotomy, correction of the deformity and lengthening, and you see the end picture. With follow-up, we had valgus deformity. So with the follow-up, we had a valgus deformity so we had another cora near the physis. So we put a plate and we corrected the residual valgus by guided growth. So don't be dogmatic. You can use other types of treatment. So early correction of anterolateral bowing in children with neurofibromatosis 1 is valid. What's the surgical treatment dilemma? We have many types of surgical treatment. Nowadays, we have three important ones: free vascularized graft, William intramedullary node, and Elizarov method. Again, surgical dilemma, because it's not one entity, and we have many difficulties. What are the difficulties? Marked deformity, technical difficulty, very small segment, scars from previous operations, severe osteoporosis and shortening. Sometimes you have all of the above. You have severe deformity, 100 degrees angulation, technical deformity, very small segment. You cannot hold it with a nail or with an external fixator or something. Scars from previous operation, scars you don't like. The patient has plating and you don't want this scar, you want another scar. Severe osteoporosis, it's very difficult to hold the small bones. And severe shortening, 17 centimeter shortening, more than 100% of the length. So if you want to treat, how are you going to treat all these problems? I will give you an example of the surgical difficulty. In this patient had 13 previous operations and they had 17 centimeter shortening, 17 centimeters. After 13 previous operations. This is the last one. I don't know which type of operation it is. Scars from previous operations. I don't want this scar. I want this scar. But you have to follow the first scar. Otherwise, you are going to have a soft tissue defect. Very You have to do it. You have to use the first scar, which you don't like. Marked deformity. In this patient, you have more than 110 degrees angulation. Perhaps you are going to have a problem if you correct the deformity acutely. Severe osteoporosis. This patient had 4 previous operations and now in a cast for 2 years. 2 years in a cast. So the bone is very soft. Technical difficulty. This patient had been treated by vascularized fibular graft. And look now, the distal segment, it's very small. How are you going to hold this segment? So if you speak about surgical treatment, especially in the cases treated previously, you're going to know that it's really hell. You're going to have many, many difficulties. Hardware removal. Remember that you have to start your operation by hardware removal, which sometimes is very bulky, like this patient. This is big, big plates. Sometimes you have limited options. Why? The patient has 6 previous operations. The last one was free vascularized graft. You don't even have the same fibula. You don't even have the other fibula. You have very short segments to deal with. Look to the distal segment, nothing. It's almost you have nothing to deal with. The treatment principle, Dr. Osama spoke about the speed reversal, resection of the pseudarthrosis, stable fixation, bracing till skeletal maturity, which has doubt very much. Most of our patients, they don't follow the rules. Intramedullary fixation is very important. Started with Charlie in 1956 with a Steinman pin and grafting. He explained that the greatest forces in fixation is mechanical, so far as all angulatory strains are corrected into longitudinal compression forces. Unfortunately, we have several types of nails. Are you going to use fixed nails or telescoping nails, antegrade or retrograde? What about the ankle fixation? William wrote, it's widely used in many places, they call it Charlie Williams because Charlie was the first one who used the techniques. And this is an example, 21 patients, follow-up 3 to 20 years, primary in 18 cases, amputation in 5 cases, refracture in 12 cases, 12 out of 21, more than 50% of cases, because some people think that if you put a rigid rod inside, they are going to have no fracture. This is not true. And this is an example. Again, William wrote, this is the recent paper with longer follow-up. They still have amputation in 6 patients out of 34 and refracture in 13 patients. Still, you have a problem. Free vascularized fibular graft, again, union can be achieved in more than 80% of cases, but you have to be professional. You have to have a surgical load to have this high success rate. Still, we have the problem of refracture and valgus deformity in many cases, and the donor site morbidity, ankle valgus. Bone morphogenic protein can be used, and people claim very good union rate, 71 to 86. However, with another study, it does not seem to increase the rate of union. So it appears to shorten the time to union of bone morphogenic protein 2. It improves the quality of healing in the intermediate term. Bisphosphonates also had been used in complex treatment of neurofibromatosis 1. However, there is no proof till now. Other people claim that we don't have excellent results. This is a paper by Christiansen et al. And they claim in all the papers before 2003, with all lines of treatment almost, there is some sort of deformity at the end. Now I'm going to give you as an example of Lazarov method. We are going to use the law of tension and stress. We have a high rate of primary union. Almost all my cases have been treated before. And this is the real merit of Lazarov method. My experience is 29 cases. And this is an example of this case, which I told you, severe osteoporosis. just bone transport, and this is union after 3 years. Another male patient, 4 years, with 2 previous operations, treated by thick intramedullary nerve, which fractured, bone transport, after 2 years, 5 years, and 8 years follow-up. 8 years follow-up. Again, this patient was 17 centimeter lengthening, had been lengthened. And this picture after 13 years follow-up with a deformity of the lengthening area and ankle deformity. This is after 25 years follow-up. You see. We have a deformity. And so remember that this patient had 13 previous operations. Another case, which had been treated 4 times before, we just corrected the deformity with minimal debridement as usual, and it ended up with union. Union was obtained initially in all the cases, but this is not the issue. The issue of the complications, spin tract infection, some sort of all cases. We have refractured 8 cases. One of them refractured 4 times, premature consolidation of the rigidity 2 cases, angulation at the site of pseudarthrosis in 9 cases, fracture of the rigidity in 2 cases. And I'm going to give you an example of this case which had been treated by plating. We debrided and corrected the deformity, ended up with refracture. Another application of the frame. And so we treated the refracture by reapplication of the frame. With early results, there was optimism in most of the 3 lines of treatment. So we had, initially in all cases, in Dobbs et al., they have 18 cases out of 21, initial union. Also, with Piro et al., 17 cases after initial treatment. But late results, look to the late results. In our series, we have 8 refractures. Dobbs et al., 12 refractures out of 18. We know 4 refractures. And this is the case of refracture, which had been treated by bone transport, union, another refracture, again with bone transport, and this is after 3 years and almost skeletal maturity. So refracture is the real problem. Current treatments improved greatly the rate of primary union congenital pseudarthrosis tibia. However, the risk of refracture persisted. How to deal with the refracture? How to avoid refracture? From my experience, I think these are the important points. Cross-sectional area of the healed segment. Try to make a big cross-sectional area. The time of removal of the root. You can use some sort of rodding. I will show you an example. Residual angular deformity. Perhaps this is one of the causes. Age at surgery. This is very controversial. Some authorities think that it's better to do the operation after the 4 years, but all these speak about very few number of patients. This patient presented to me at the age 18. She was treated elsewhere by bone transport and ended up with fracture. Look to the fracture sites and shortening, severe shortening. We did bone transport and lengthening area, lengthening about 11 centimeter, consolidation, and union. Look to the cross-sectional area. This is very important. Try to have a good cross-sectional area to prevent refracture. And this is long X-ray. And after a couple of years follow-up. Cross-sectional area is very important. This is the case of failure of revascularized fibrillar graft. So you almost has nothing. What we did, we remove a small piece and we make it like an arrow and we put it in the middle. It's not so clear here. Why you put a K-wire? Because after some time you cannot see those two edges. So the K-wire just will help you when you do compression. Look here to this edge. We are going to put it inside. This is very small segment. Look here, we did compression. Again, it's not, you can see nothing here because it's a very small segment. Look now to the, it looks like an arrow and casting for 4 months. And look to the picture. This segment has been implanted in the small. Those are the tactics to prevent refracture. It's not just Elizarov. You have many other tactics to prevent refracture. With long follow-up, we have axial malalignment. After 5 years, we see valgus deformity. We did another osteotomy and to correct the mechanical axis and length. And this is after correction of the mechanical axis. You see the correction and lengthening. Very solid union, no refracture, because you have, look to the site here. It's very difficult to have refracture here with longer follow. How to prevent refracture? I will give you another tactic of prevention of refracture. You see this picture of this patient with congenital pseudarthrosis tibia. During the removal of the fixator, we apply many wires from distal to proximal and put the patient in the cast. And then we raise the heel with part of the foot and we let the patient walk for 3 months. Then after removal, we make an X-ray. This is very good union, as you see in the X-ray. Then we put him in another cast. And we let the patient walk for 1.5 months. Then we remove the wires. And then we let the patient walk for a couple of weeks. You see here, after removal of the wires. Now we are sure that there is no problem at all. And you see with the follow-up. This is another way of prophylactic treatment against the development of refracture. لأن الريفراكشر دوخ العالم. يعني الميثودز اللي أنا قلتها الثلاثة قدروا يعملوا برايمري هيلينج كويس، نسبة في حدود 80%. بس none of them الحقيقة قدرت توقف موضوع الريفراكشرز. الحقيقة الميثودز اللي أنا I developed في خلال الفترة دي كلها مع الحالات how to stop the refraction أو تمنع الريفراكشر. In conclusion, currently 3 different surgical approaches are valid for treatment: vascularized bone graft, intramedullary stabilization, and external fixation. They are all successful in having a primary union of congenital pseudarthrosis tibia. However, despite that success, the quality and the longevity of the consolidation and the future function of the involved extremity remain uncertain. Primary union alone cannot be considered at the ultimate index of success. ما تفرحش قوي تقول لي لا أصل أنا لحمت معايا، لا. دي عملية هتقعد فترة طويلة. لازم يكون عندك خبرة عشان تتعامل. يا إما تمنع الريفراكشر يا إما تتعامل مع مشكلة الريفراكشر، لأن هي دي المشكلة الحقيقية اللي العالم ما قدرش يتخلص منها. Elizarov method has an important role in treatment of congenital pseudarthrosis tibia with a high union rate. The possible complications of refracture or axial malalignment can be avoided. أنا شرحت لكم إزاي to avoid these problems. Refracture. خلي بالك الأكسل malalignment البيبر بتاعت الكريستيان سنتال كان بيراجع على الناس كلها وقال لك لا 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 ده كل الحالات بتاعت congenital pseudarthrosis في تيبيا اللي الناس بتقول التريتمنت بتاعها very successful كلهم فيهم axial malalignment. But معانا we can avoid it and we can treat it. زي ما وريتكم الحالة مع long standing حصل progressive valgus, you can treat it with guided growth أو with osteotomy. How to prevent the refracture, how to treat the refracture. Prevent the refractures وريتك الميثود وعندك فيري شورت سيجمنت وغالبا ستيف انكل لانه عمل 6 عمليات قبل كده او 5 عمليات، فالستريسز عاليه جدا. فانت بتزود الكروس اريا زي ما انت شفت، وبعد كده بتسيب وايرز، واحنا بنشيل الفريم اندر انستيزيا بنحط وايرز 5 أو 6 وايرز. لما بتحط الوايرز انت بتستيميوليت البون فورميشن اكتر، وبتسيبه يمشي عليها، بتستيميوليت البون فورميشن. بعد 13 ونص بتشيل الوايرز، وانت بتشيل الوايرز يو ستيميوليتد اجين الاريا. الاستيميوليشن ده بيزود لك الكالس فورميشن ان ذيس اريا. كل دي زي ما يكون 3 أو 4 محاولات علشان خاطر تزود البون فورميشن في this critical area. So the possible complications of refracture or axial malalignment can be avoided and treated with residual defects. شكرا يا جماعة.